Start. A very good morning to one and all present here. So, my topic is a rational approach to paracetamol poisoning. Paracelsus, father of toxicology, once said, "Poison is in everything and nothing is without poison. The dosage makes it either a poison or a remedy." And we all know even love is valuable only if it is given in the right dosage. And overdose of drugs, especially paracetamol, can lead to serious complications, including liver failure in children. Two types of overdosing commonly occurs with respect to paracetamol. One is accidental, when the child drinks up some quantity of paracetamol, if it is tasty, or more doses are taken by mistake. The other common scenario is anxious parents overdose their children with paracetamol. They give drops instead of syrup, or double strength syrup instead of normal dose. Oral paracetamol are available in different values across different brands. There is a double strength version which they buy instead of regular dose. Parents sometimes mistake the drops version for the syrup. Objectives of my talk includes: is it a case of acute poisoning? What toxin is it? What are the steps in immediate management? Which gastric decontamination method to be followed? How can elimination be enhanced? And management of paracetamol overdose. We had a patient, Master K, 2 years old, male child, hailing from Viluppuram, Tamil Nadu. His date of admission was 12/10/21 and date of discharge was 15/10/21. The chief complaint was alleged history of ingestion of paracetamol syrup half an hour back while the child was playing, and around 50 ml of the syrup was consumed. 5 ml contained 250 mg. And there was no history of nausea, vomiting, malaise, anorexia. There was no history of abdominal pain or sweating. So the diagnosis was paracetamol overdose. In this case, 208 mg per kg he had consumed. So is it a case of acute poisoning? Yes. What toxin is it? Paracetamol overdose. What are the steps in immediate stabilization? So emergency cardiorespiratory stabilization and basic life support must precede any diagnostic steps in poisoned child. The goals in emergency management includes initial life support phase, ABCD3EF, history and focused examination, known toxin versus unknown toxin exposure, identify toxidromes. Toxidrome is syndromes caused due to ingestion of the toxin, a sequence of events caused due to the ingestion of toxin. And appropriate decontamination procedures, administration of specific antidotes when indicated. So emergency management is similar to multiple trauma model. Poisoning is injury to multiple organs, ABCD3EF approach. So what is this approach? A is airway, breathing, circulation, disability, drugs, decontamination, ECG, and fever. So airway is emphasis on protection of unattended child and possible compromise in caustic exposures. Breathing is adequate oxygenation and ventilation. Circulation is close monitoring of vital signs, capillary perfusion, and early IV access. Disability is level of consciousness, pupil size to be checked. And drugs, dextrose can be given, oxygen, naloxone, ACLS medications if needed. Decontamination, ocular manifestation, then you give a saline wash. Skin manifestation, you remove the contaminated clothes. ECG to be checked, and rate and rhythm, QRS with QTC length, and terminal R wave in lead AVR to be checked. And fever, core temperature check for hyperthermia, emergent cooling as needed. So in this index child, airway was open and stable, breathing was normal, respiratory rate was normal for his age, and air entry was equal, saturation he was maintaining in room air, circulation, heart rate was normal for his age, and BP and CFT was normal, skin temperature, ECG was normal. Disabilities, GCS was 15/15, pupils were pupils 2 mm and reacting to light equally, and symmetrical and normal and symmetrical motor activity was noted. The RBS was normal, 108. Exposure, color normal, and surface findings were absent. So he was under level 2 emergent stable condition. And systemic examination, anthropometry, weight was 12 kg, length was 93 cm, and Head circumference was 47 centimeter. There was no pyelorectus, cyanosis, clubbing, lymphadenopathy, and his severe systemic examination was normal. History, time of exposure, the toxin ingested and quantity, how much was taken, details of pre-hospital management, what was given before referral to your hospital is important, and circumstances of exposure. Review the product container. It is important to review the product container label to know the precise ingredients. Sometimes the combination of drugs might be present, and presume the worst case scenario when in doubt. So in this child, the ABCD was stable on arrival at emergency. Accidental exposure is paracetamol, and the dosage is 208 mg per kg. Presented at half an hour post ingestion. No additional drugs were implicated, and ECG was normal, and there was no fever. So next is which gastric decontamination method to be followed, and how can elimination be enhanced. So when there is an acute single overdose of paracetamol, and if the child presents within 4 hours, then especially if at arrival less than 1 hour since ingestion, and the dose is more than 140 mg per kg, we need to consider activated charcoal. Activated charcoal is best effective if it is given before 1 hour. And we need to check the acetaminophen level at 4 hours. So the peak level is reached only at 4 hours. So if the child presents before 4 hours, you will wait till 4 hours and then you will check the acetaminophen level. And you plot it in a rheumatic nomogram and start NAC if on or above, and you plot it in a graph, and if it is above the treatment line, you will start NAC. If the child presents between 4 to 8 hours, then you check the acetaminophen values immediately. And if not available before 8 hours, then we need to start NAC immediately pending investigation. Then again, you plot the level against time on rheumatic nomogram and start NAC if it is above the line. Gastric lavage. So gastric lavage is also best, its effectiveness is best if it is given within 1 hour. That is the golden hour. Life-threatening ingestion, we need to give gastric lavage. Yeah, nasogastric tube is not adequate. Large bore OG tube should be used, and NS can be given 15 ml per kg. Maximum 200 to 400 ml per cycle to be given. And it is not routinely recommended, but if it is given, then it's in the proper procedure has to be followed. If the presentation is less than 1 hour, then it is strongly recommended. What are the contraindications for gastric lavage? Caustics, hydrocarbons, sharp ingestion, and complication includes pulmonary aspiration. Procedure for gastric lavage. So left lateral decubitus position is preferred. As you can see, the pyloric emptying is enhanced if the child is placed in right lateral decubitus position. So ensure the airway protection. Left lateral decubitus head down position is preferred, and measure the tube insertion distance and mark the tube. Lubricate the tube and insert gently through the mouth to the predetermined distance. Next is activated charcoal. Activated charcoal have been efficacious since 1700 AD, and the pores present will absorb the drugs and other large molecular weight substances. Effectively absorbs almost all toxins. Maximal absorption of toxins by activated charcoal occurs when the charcoal drug ratio is 10:1. Criteria for using activated charcoal. Ingestion that are potentially toxic with no safer alternative. Massive dose of ingestion. Absorbable toxins. Greatest benefit within 1 hour after ingestion. And toxin if it is still present in the GIT or GI functionally or anatomically intact. No other contraindications or intubated or patent airway, then we need to give, then we can consider activated charcoal. The dose is up to 1 year, 1 gram per kg, and from 1 to 12 years, 25 to 50 grams, and more than 12 years, 25 to 100 grams. The dark side of charcoal. Side effects includes vomiting, which is present in 16 to 20% of the cases, aspiration pneumonitis, poor acceptability in children, only 30% agreed for voluntary ingestion. Intestinal complications includes constipation, obstruction, perforation, and ingestion of caustics and loss of airway control. So toxin that poorly bind to activated charcoal includes the chemical is the mnemonic: cyanide, hydrocarbon, ethanol, metals, iron, caustics, lithium. So next is specific antidote for paracetamol poisoning. The same slide which we saw earlier, the specific antidote is NAC, N-acetylcysteine. So N-acetylcysteine, if child is presenting before 4 hours, we need to plot in the graph, and then if in rheumatoid nomogram, and if it is above the treatment line, we will start treatment. Child presents in 4 to 8 hours, then we will send investigations and we can start NAC. After the report, we plot on the graph and we start treatment. So this is our rheumatoid nomogram. The thick line is the treatment line, and once our reports are available, blood acetaminophen levels are available, we plot it in the graph, and if it is above the line, then we start the treatment. When this is not useful, that is the rheumatoid nomogram, when it is not useful, if the child presents before 4 hours, it is not useful, and if the child presents after 24 hours, not useful. And also in chronic ingestion, this is of less use. Patient needs treatment with NAC, yes, then you need to send investigations, RBS, AST, ALT, INR, PT-INR, and serum electrolytes, urea, creat, lactate, and arterial pH to be sent. And repeat every 24 hours when you are giving NAC, oral NAC or IV NAC. And if not a necessity of NAC, then no investigations to be sent, and only supportive treatment to be given. In this child, the sodium was on the lower side, the potassium was normal, urea, creat, SCOT, SCPT was normal. The pH was 7.32 at 12 hours, and bicarb was decreased, base excess was mildly elevated, and high anion gap metabolic acidosis was noted. PT-INR was normal. So at half an hour of arrival, decontamination was done with the activated charcoal and gastric lavage. After that, since the dosage was high, antidote NAC was started. Loading dose of IV NAC is 150 mg per kg. Then you give 50 mg per kg for next 4 hours, and then you give 100 mg per kg for next 16 hours. So the total duration is 21 hours for oral NAC, for IV NAC. And for oral NAC, the loading dose is the same, 150 mg per kg. Maintenance dose is 75 mg per kg. You repeat it every 4 hours for 17 doses. So that also amounts to 21 hours of therapy. And many studies have said it is equally efficacious, oral NAC and IV NAC. If the child is presenting earlier, oral NAC or IV NAC, both either of these can be given. And if child is presenting late, then IV NAC is preferred. Acute toxic dose. In the US, acute paracetamol poisoning, most common cause of acute liver failure, recurring transplantation. Repeated administration of 75 mg per kg per day will result in hepatic injury or failure in the setting of fever, dehydration, malnutrition, and enzyme-inducing drugs, namely rifampicin, phenobarbital, these drugs. And if the dosage is more than 200 mg per kg in children, repeated dosage, then it is toxic. More than 7.5 to 10 gram in adolescents and adults is also considered toxic. Mechanism of toxicity. So acetaminophen, 90% of acetaminophen is converted to glucuronate and sulfate moiety, which are non-toxic. So this occurs by conjugation. And the remaining 10% is oxidized by cytochrome P450 into NAPQI. This is the toxic compound. And this NAPQI is normally conjugated by glutathione to non-toxic component cysteine and mercapturic acid. What happens in paracetamol poisoning? NAPQI levels increases. Glutathione levels also increase, but relatively NAPQI levels are more. So the conversion to non-toxic compounds is not that adequate enough, and this NAPQI causes hepatocellular injury. So what is the mechanism of NAC? So NAC, when you give, it increases the levels of glutathione, and hence the toxic effects of NAPQI is decreased by converting it into non-toxic compounds. And also some oxidizing property is there with NAC. Stages of paracetamol toxicity. Stage 1 is till 24 hours. Anorexia, nausea, vomiting might be present, and metabolic acidosis might be present. Stage 2, 24 to 48 hours. elevated bilirubin, PTINR, transaminases, oliguria might be present. SCOT might be elevated specifically, and SCOT elevation may occur earlier than PTINR abnormality. And stage 3, 72 to 96 hours. Fulminant hepatic failure can occur. Metabolic acidosis and renal dysfunction can occur. Fulminant hepatic failure typically occurs between 3rd to 5th day. And stage 4, 5 to 14 days. Resolution of hepatic dysfunction in survivors can occur. Mostly resolution or regeneration of the hepatocytes occur by 5 to 7 days. Death in patients with fulminant hepatic failure can occur due to cerebral edema or sepsis. These causes multi-organ dysfunction. So N-acetylcysteine, within 8 hours of an acute ingestion, hepatic injury can be prevented in nearly all patients. Deaths are highly unlikely in patients treated prior to 16 hours following an acute overdose. In fulminant hepatic failure, IV NAC may be of benefit as early as 36 to 80 hours. Indicators of poor prognosis. So King's College criteria is also included in this. INR more than 2 at 24 hours, 4 at 48 hours, or 6 at 72 hours. Persistent metabolic acidosis is single most important factor apart from rising PT on day 4. And serum creat more than 3.4 mg per DL or PTI more than 100 seconds, grade 3 or 4 hepatic encephalopathy. If all these are present, except persistent metabolic acidosis, which is a major criteria, all other criteria are present, then we need to consider liver transplantation. Rising PT on 4th day after overdose, the single best marker for poor prognosis. Disposition of patients. Healthy patients with concentration below the lower normogram line require no further treatment. Patients with no evidence of hepatotoxicity can be managed in a non-monitored setting, that is in ward, for supervised NAC treatment. And patients with progressive hepatotoxicity or fulminant hepatic failure require intensive care. In our child, he had no evidence of hepatotoxicity. He was discharged after 4 days. Parents were counseled regarding safe handling of drugs. Other modalities of treatment includes liver transplantation if the child fits into King's College criteria, and ECMO, which for the indications include altered mental status, metabolic acidosis, elevated lactate, or extremely high dose of blood acetaminophen levels. Other modalities of treatment, hemodialysis, it also removes NAC, and hence NAC infusion rates should be increased. And plasmapheresis may be useful in acute liver failure to correct coagulopathy, but it does not correct encephalopathy. These are the recent advances being tried in Western countries. Newer concept is liver dialysis. Just like your renal dialysis, there is a concept called liver dialysis, and it includes a molecular adsorption recirculation system, fraction plasma separation and adsorption, single pass albumin dialysis. Multiple dose and extended release acetaminophen injection, and in such a case you need to recheck the value after 4 to 6 hours. So first you will check at 4 hours and then you will recheck at 4 to 6 hours, and if it is high, then you need to give NAC. The treatment is the same. And other recent advances, acetylcysteine infusion regimen. Instead of 150 mg per kg, we can give 200 mg per kg over 4 hours. High dose is preferred. Then 100 mg per kg over 16 hours. This significantly reduced the adverse reactions compared with previous 3-bag regimen. And modified release paracetamol injection more than 200 mg per kg should receive a full course of acetylcysteine. Patients ingesting more than 30 grams or more than 500 mg per kg should receive increased dose of acetylcysteine. So take home message, management of children with leak poisoning then involves attention to ABC and decontamination procedures where applicable. Decision making is clinical in most of the situations, and antidotes are available for handful of poisoning and have a role after initial stabilization. So these are some useful poison helpline numbers. It works 24/7. CMC Vellore. There they do serum paracetamol levels. The approximate cost is 1,500 rupees. The report might be available within 1 day. And AIMS toll-free number 24 hours. If any doubt, we can call them. So thank you. There are some poisons that blind you and poisons that open your eyes. Thank you for your patient listening.
Thank you, Dr. Anandkumar, for a very, very excellent talk. This again reiterates the ethical responsibility on the part of the practicing pediatrician, especially if you forget to write the decimal when you are prescribing drops. There is a danger of the child getting more than its usual dose. For example, 0.5 ml can be misinterpreted as 5 ml, and 3 or 4 times a day in a newborn, which is just a month old, can lead to toxicity, especially when the liver is